We did this study because we've noticed that male breast cancer today is still an understudied disease, unfortunately. And recent differences have emerged with regards to comparisons with female breast cancer, in particular in terms of molecular characteristics of tumor subtypes, and also at the genomic level there are differences between male and female breast cancers. So the aim of our study was to do a large-scale independent analysis of male breast cancer patients to look into their patient characteristics and their prognostic factors over the last 10 years. So our patient population actually comes from the SEER registry program. So the study was done in collaboration with the GOX Oncology Cooperative Group from Argentina, the University of Iowa, and the University of Pittsburgh. But we took data from the SEER registry program, which is an NCI program that covers around 26% of the United States population. So we found that most patients with male breast cancer, as opposed to common belief, most patients are actually diagnosed at early stages of disease. Most tumors have most patients have high rates of ER and PR positivity, although of interest, grade 1 appears to be uncommon in our study. And in most cases, when patients have high rates of ER and PR positivity, tumors tend to be more commonly grade 1, and this appears not to be the case in male breast cancer. Furthermore, grade was a very strong prognostic factor for patients, and patients' characteristics were significantly different according to grade. In addition, we found that the estrogen receptor, as a marker for survival, patients who were positive for the receptor for estrogen had better survival. However, that improvement in survival was mainly observed within the first 5 years of the analysis, and after that period of time, the survival appeared to be similar, whether patients were ER positive or ER negatives. And we found that many of the factors that we analyzed for prognosis were actually predictors of that endpoint. In particular, age at diagnosis, stage, tumor grade, as I said, and the estrogen receptor status. Also, treatment variables like mastectomies or radiation therapy were independently linked to prognosis in the multivariate analysis. So we did find interesting differences. One of them was the finding of low rates of grade 1 disease. So grade 1 was lower than what has been traditionally reported in female breast cancer patients. We've also observed higher rates of estrogen and progesterone receptor positivity compared to female breast cancers. In male breast cancer, that encompasses about 90% of cases, more or less, whereas in female breast cancers, that is usually in the range of 60 to 70%. We've also seen differences in the way patients survive when they are ER positive in male breast cancers compared to female breast cancers. Usually female patients with estrogen receptor positivity do hold that advantage in survival for a longer period of time, whereas we did not see that in male breast cancer patients. So I think the take-home message is that male breast cancer is a very important disease, that we should not always extrapolate the data that we have from female breast cancer into male breast cancer, particularly for prognostic analysis, but also for treatment decisions, and that research should still continue to be done in male breast cancer as well, not only to understand better the factors that I've mentioned that we've clearly seen improvements in prognosis, but also to analyze other factors as well and try to understand how treatments could be applied in male breast cancer to improve their outcomes.